A very good afternoon to all of you. On behalf of Department of Emergency Medicine, I invite you. I I'm on behalf of Emergency Medicine. I'm actually inviting you for this clinical combined round. And few days back, we got a very intriguing case in the Department of Emergency Medicine, where the patient came to our emergency in profound shock with very less or no urine output. So the case will be discussed by Dr. Shisha Nair, who is second year's emergency medicine student. It will be followed by case discussion by Dr. Archana Nair. So I would like to invite Dr. Shisha Nair for the case presentation. Thank you.
Good afternoon, everyone, respected faculty members, my dear seniors and colleagues. So I'll be presenting the case scenario. I'm Dr. Shrisha Nayak from the Department of Emergency Medicine, a second year postgraduate. So a 39-year-old male patient presented to our ED with acute onset of loose stools and vomiting. On primary survey, the airway was patent. His saturation was 98% on room air with a respiratory rate of 24 with increased work of breathing. However, the chest was clear on auscultation. He was started on oxygen at around 10 liters per minute by face mask. His heart rate was 130 beats per minute with the non-recordable non-invasive blood pressure. His peripheral pulses were poor with a raised capillary refill time of more than 3 seconds. His peripheries were found to be cold and clammy. Two large bore IV cannulas were secured and IV fluid RL boluses were started. His GCS was full with a random blood sugar of 150 milligrams per deciliter and he was moving all limbs on commands. He was afebrile to touch. A Foley's catheter, which was placed, showed a urine output of around 150 ml when he had last passed urine approximately 5 hours ago. A initial blood gas revealed a pH of 7.17 with the CO2 of 32.2 and a bicarbonate of 16.9 and a lactate of 7.4. This was suggestive of metabolic acidosis, a high anion gap metabolic acidosis. A point of care ultrasound was done as per the rapid ultrasound in shock and hypotension protocol, which showed cardiac contractility to be hyperdynamic with no evidence of right atrial or right ventricular dilatation. Inferior vena cava was found to be collapsing. On lung scan, there was bilateral A profile, which is essentially normal, and there was no evidence of intrathoracic or intraabdominal fluid. So coming back to our history, he was a 39-year-old male resident of New Delhi, office clerk by occupation. He presented with vomiting and loose stools for 3 hours. Vomiting was sudden in onset, approximately 15 to 20 episodes contained food material, 2 episodes of which contained approximately 10 ml of blood, which was non-bilious and non-projectile. Loose stools were sudden in onset approximately 10 minutes after the onset of vomiting, approximately 15 episodes, initially watery, followed by fresh blood, not containing mucus. However, tenesmus was present. This was associated with diffuse abdominal colicky type of pain, which was non-radiating and relieved on passing stool. With this history, we came to a possible differential diagnosis of infectious gastroenteritis, possibly by a preformed toxin, anaphylaxis, toxin ingestion, likely organophosphorus, mushroom, or arsenic, or acute myocardial infarction, or sepsis with septic shock. However, there was no history of fever or drug intake, lump sensation in the throat, itching or rashes, consumption of street food, mushroom, or seafood. There was no exposure to toxic fumes and no salivation, excessive tears, urinary incontinence, retching, or pain or burning sensation in the chest. He was a known hypertensive for 4 years and was not on any medications. There was no history of alcohol consumption, tobacco use, smoking, or use of any recreational drugs. There was no significant family history and no similar complaints in family members. We went ahead with the focused examination wherein he was found to be conscious, well built and nourished. However, on head to toe examination, he was diaphoretic. There is no ptosis or epiphora, and pupils were equal and normally reactive to light. The tongue was, however, found to be dry and coated. There were no rashes or hives, periorbital edema, or lip swelling. In systemic examination, there was increased work of breathing with accessory use of muscles, and there was no stridor, and chest was clear on auscultation. There were no wheeze or crepitations. In abdomen, the abdomen is soft, non-tender, and non-distended, and bowel sounds were found to be increased. There were normal heart sounds heard and no murmurs. Initial ECG revealed a sinus tachycardia, and complete blood count showed a hemoglobin of 22.8 and a hematocrit of 66.8. The total leukocyte counts were 42,700 with a neutrophilic predominance of 72%, and initial troponin I was found to be negative. We also sent liver function tests, kidney function tests, blood and stool cultures, and peripheral smear. So, coming back to our differential diagnosis. The first differential diagnosis that we considered was infectious gastroenteritis, second one being anaphylaxis. However, for anaphylaxis, there was no history of any skin involvement or no angioedema, periorbital swelling or stridor. So we ruled it out. There was no history of salivation, lacrimation, urination, and there was no bradycardia. In fact, there was tachycardia. So we ruled out organophosphorus poisoning. There was no history of mushroom ingestion, so we ruled out mushroom poisoning as well. And for arsenic, there was no history of exposure to toxic fumes or any other family members being affected by the same illness. So we ruled out arsenic poisoning. For acute myocardial infarction, we considered this because it was of very rapid onset. A 3 hour history with severe vomiting and patient presented in shock. However, there was no history of chest pain, burning sensation in the chest, and initial ECG and troponin was negative. So we ruled out MI. And for sepsis, the presentation was of very short duration, and there was no history of fever, and there was no clear-cut source of infection other than loose stools. So we ruled out sepsis as well. So we considered acute gastroenteritis as our diagnosis, and we went ahead with fluid resuscitation. We gave him IV antibiotics, that is ciprofloxacin and metronidazole, and pantoprazole infusion was started in view of hematemesis. In view of persistent nausea, we also gave ondansetron. However, the patient gave history of consumption of bottle gourd juice every day for the past 4 years for hypertension and hyperlipidemia. He had consumed bottle gourd juice approximately 300 ml 5 minutes prior to the onset of vomiting. He found it to be unusually bitter. With this history, we came to our diagnosis of bottle gourd poisoning, also known as toxic squash syndrome, caused by cucurbitacin toxicity. It is also popularly known as Loki, Ghia or Dudhi in Hindi. So, 2 hours after the initial presentation, the tachypnea and work of breathing had reduced. The heart rate had come down to 122 and now he had a recordable BP of 90/60 after 2.5 liters of fluids. There was no urine output and loose stools still persisted. Repeat point of care ultrasound showed a collapsing IVC with bilateral A profile. There is no evidence of pulmonary edema in the lungs. A repeat venous blood gas showed a pH of 7.22 with a lactate of 7.2 and bicarbonate of 17. After this, the oxygen flow was reduced and fluid boluses were continued. After 6 hours of initial presentation, the work of breathing was now normal with the resolved tachypnea. And heart rate had come down to 120 with BP being 100/60 after 5 liters of fluid. Still there was no urine output. A repeat point of care ultrasound showed approximately 50% collapsible inferior vena cava with bilateral A profile. And a renal scan was done to rule out any acute kidney injury as there was still no urine output and it was essentially normal. Repeat blood gas showed a pH of 7.24 with a lactate of 7.6 and bicarbonate of 17.6. In view of persistent lactic acidosis, fluids were continued at around 500 ml per hour and in view of normal breathing, the oxygen was stopped. In view of nil urine output, a urine albumin and urine albumin creatinine ratio was sent. And the initial liver function test which we had sent showed a slight increased transaminase. At around 15 hours after presentation, breathing was normal and heart rate had come down to 106 with the BP of 110/68 after 10 liters of fluid. Now there was approximately 150 ml of urine output. A repeat point of care ultrasound showed less than 50% collapsible inferior vena cava with bilateral A profile in the lungs. A blood gas showed a pH of 7.428 with a lactate of 5.1 and bicarbonate of 19.6. Fluids were continued and oral intake was encouraged. Ultrasound abdomen was normal and repeat ECG was also normal. After 24 hours, the breathing was normal. The heart rate and BP had now come back to normal with after 12 liters of fluid and there was 650 ml of urine output. A repeat point of care ultrasound showed less than 50% collapsible IVC and bilateral A profile. A blood gas showed pH of 7.41 with a persistent lactate of 4.3 after 24 hours and bicarbonate of 22.8. Fluids were continued and now he was tolerating orally. At 36 hours, the breathing was normal, circulation was normal, and now he had a normal urine output also with the point of care ultrasound showing less than 50% collapsible inferior vena cava and bilateral A profile. Now, the repeat blood gas was also normal with the lactate of 1.9. By now, the repeat liver function test which was sent were also normalized, and stool which was sent initially was negative for leukocyte and hanging drop was also negative. Fluids were continued at 75 ml per hour. This shows a trend of blood gas, total fluids given, and total urine output. And it also shows the urea and creatinine at a serial interval. The point to be noted over here is from presentation to approximately 10 to 12 hours of initial resuscitation, there was no urine output, and the urine albumin and urine albumin creatinine ratio were deranged. Despite this, the urea and creatinine was normal, and there was no features of azotemia. We also gave aggressive fluids, that is approximately 12 liters of fluids in 24 hours, approximately 500 ml per hour. With the use of point of care ultrasound, there was the patient did not go into fluid overload despite such an aggressive fluid resuscitation. This shows the table of trend of complete blood counts and lactates. The initial hemoglobin, hematocrit, and total leukocyte count, which I have considered as baseline, were obtained approximately 2 months ago by the patient himself as a routine investigation at an outside lab. The initial hematocrit and hemoglobin shows severe hemoconcentration, which serially decreased and was completely normal by the time of discharge after fluid resuscitation. Upper GI endoscopy was done, which was showing Los Angeles B esophagitis, and in the stomach there was diffuse hyperemia with erosion suggestive of pangastritis. So, summarizing the whole case, at around 7:30, he had consumption of bottle gourd juice, approximately 300 ml. After 5 minutes, he had onset of vomiting, and after 10 minutes, he had onset of loose stools. After approximately 1.5 hours, he presented to a local hospital where his vitals were recorded to be heart rate as 88 beats per minute and blood pressure of 128 by 76. He was given 500 ml of NS, pantoprazole, and ondansetron, and referred to AIIMS in view of hematemesis. Here, the vomiting subsided, however, the loose stools persisted. At around 20:55, that is 3 hours after ingestion of bottle gourd juice, he had presented to our ED, where he was triaged red and shifted to the resuscitation area, and aggressive resuscitation with fluids was done. On day 1, loose stools and vomiting subsided, however, the malaise persisted. Urine output was now normal with the normal vitals and normalized lactate. On day 2, liver enzymes were also normal, however, there were 2 episodes of loose stools and no vomiting. On day 3, he was symptom free with a general feeling of well being. On day 4, upper GI scopy was done in the morning and the patient was discharged from the ED in a stable condition. So, this was our final diagnosis: acute cucurbittis and toxicity, causing hypovolemic shock and severe hemoconcentration, which had resolved by discharge, acute kidney injury, which had also resolved, and esophagitis and pangastritis. Now, I'd like to call upon Dr. Archana, senior resident in the Department of Emergency Medicine, to discuss the case. Thank you.
Good afternoon, respected faculty and dear colleagues. So, continuing with the discussion of bottle gourd toxicity. Bottle gourd or calabash is an edible plant in the Cucurbitaceae family. The botanical name is Lagenaria cicererea. It is popularly known as Lauki Gia or Dudi in India. Other members of the family are cucumber, zucchini, snake gourd, squash, pumpkin, and bitter melon. So, why are we worried about this family of vegetables? Times of India in 2018 has reported a news Pune woman dies after drinking bottle gourd juice. The Times of India in 2021 reports another news Tahira Kashyap gets admitted in the ICU, suffers side effects of having bitter bottle gourd juice. She being a writer, director and Mrs. Ayushman Khurrana, this news has gained widespread popularity among netizens. As doctors, we are interested in case reports more than news reports. These are various case reports published in national and international journals regarding bitter bottle gourd toxicity. Coming back to bottle gourd, this vegetable is used by traditional medicine healers for the treatment of various diseases like diabetes, hypertension, dyslipidemia, weight loss, liver diseases, and some other conditions. The toxic component is cucurbitacin, which is a tetracyclic triterpenoid compound. This compound is responsible for the bitter taste as well as toxicity of this vegetable. More the amount of cucurbitacin, more bitter will be the vegetable and more toxic will be the vegetable. Basically, this bitter taste is a nature's protective mechanism to prevent it from consumption by herbivores, other animals or human beings. Bioactivity of cucurbitacins include it has got anti-inflammatory, anti-tumor action, anti-atherosclerotic activity, anti-diabetic action and purgative action as per literature. All this seems to be good actions. So why are we worried about this group? Bottle gourd contains cucurbitacin B, D, G and H. Higher levels of cucurbitacin are seen when bottle gourds are grown under environmental stress, extremes of temperatures, drought, poor soil quality and low soil pH. When the vegetable is over ripened or when there is cross pollination with wild plants which have a comparatively higher level of cucurbitacin. Toxic squash syndrome is an entity for the clinical features which happen after consuming foods which are rich in cucurbitacin. The mechanism of toxicity as given in literature is it inhibits the binding of cortisol to the glucocorticoid receptors in HeLa cells causing cytotoxicity which was demonstrated in animal models. Cucurbitacin D enhances the capillary permeability. This explains the hypotension and third space fluid losses. It inhibits the JAK-STAT pathway and MAPK pathway, that is the mitogen activated protein kinase pathway, inhibition of both pathways which will eventually lead to cytotoxic effects. Coming to the clinical features, the symptoms occur within minutes to 1 hour of ingestion. Predominant clinical symptoms are multiple episodes of vomiting, diarrhea, abdominal pain, upper GI bleeding and patient can present in profound hypotension. This resembled the clinical picture of our patient. This is a case series published in the Indian Journal of Gastroenterology, a case series of 15 patients. Here we can see onset was 15 to 30 minutes in most cases with a maximum time of 360 minutes. All 15 patients presented with pain abdomen and vomiting. Among the 15 patients, 13 patients had hematemesis, majority of them had diarrhea and most of their patients also presented in hypotension. Of the 15 patients, the 12 patients who had upper GI bleeding underwent endoscopy, in which 6 patients had esophageal erosions. All 12 patients had stomach involvement, which was hyperemia, erosions, and ulcers. Body of stomach was predominantly involved than fundus. There was proximal duodenal involvement in all 12 patients, which was again hyperemia followed by erosions. Our patient on upper GI endoscopy had esophagitis, lozenges grade B, and pangastritis. This was an article published in the Indian Journal of Medical Research, Assessment of Effects on Health Due to Consumption of Bitter Bottle Gourd. This article was published by an expert committee which was formed by the ICMR under guidance of Dr. S.K. Sharma. They reported 26 cases which were spread like this, 16 from the NCR, 7 cases from Madhya Pradesh, 2 from Gujarat and 1 from Uttarakhand. Among the 26 cases, there were 3 deaths reported. These are the clinical details of the three deaths reported. Case 1 and case 2 were 68 and 59-year-old male and female patient respectively from Amroha, UP. They belong to the same family, husband and wife. Date of occurrence of event was 28th of March 2007. Both of them expired on the same day, 8 hours later. Quantity was 100 ml consumed, and the juice, both of them had consumed it for the control of diabetes mellitus. The third patient was a 59-year-old male from Delhi. Date of occurrence was 23rd of June 2010, expired on the same day 4 hours later. He also, as per history, consumed the juice for the control of diabetes mellitus. One thing which is commonly noted in all the three cases is the level of bitterness on the day of incident was all three patients reported it as extremely bitter. So the clinical profile of all these 26 patients were again similar to the clinical profile we have earlier mentioned. Abdominal pain, vomiting, diarrhea, nausea, hematemesis, hematochezia, melena, and decreased urine output. Coming to the diagnosis is entirely clinical. History and clinical examination is very important. Without eliciting proper history, we may never come to a diagnosis of cucurbitacin toxicity. In history, the most important point which we have to ask is, was the vegetable or the juice extremely bitter or unusually bitter? Lab investigations are for the supportive management of the patients. Complete blood count to look for hemoglobin in case of upper GI bleed and to look for the degree of hemoconcentration. Blood gas analysis to look for the lactate and other metabolic parameters. Liver function test because there can be transaminitis. Renal function test to look for evidence of acute kidney injury. Ultrasound abdomen to rule out other causes and an upper GI endoscopy. Complications, it can lead to hypovolemic shock, acute kidney injury, transaminitis, GI mucosal injury, gastric necrosis, gastric perforation, pancreatitis, and eventually death. Management, the patient is triaged as red and we follow the systematic approach of airway, breathing, circulation, disability, and exposure. Here mostly the circulation part will be impaired, for which we secure two large IV bore lines and start isotonic crystalloid boluses followed by IVC guided resuscitation as per the rapid ultrasound in shock and hypotension and fluid administration limited by lung sonography protocol. Blood transfusion and inotropes should be given to support hemodynamics if needed. There is no specific antidote for cucurbitacin toxicity. Management is entirely supportive with antiemetics, proton pump inhibitors, and hemodialysis if the patient develops AKI. How to prevent toxicity? We have to raise awareness but do not create panic. Do not consume if bitter. And we should not fall for such fake news. Do not blindly believe internet and there are no shortcuts for lifestyle disorders. So next time when somebody is offering you a glass of bitter bottle gourd juice for weight loss, please say no thanks because I have got a healthy lifestyle. Thank you.
Thank you, Dr. Archana. So bitter gourd toxicity or cucurbitacin toxicity is not new. It was first reported in 1984 from various parts of USA. Almost 202 cases were reported in different parts, mainly from Alabama region and from California region. And again, 1994 in United Kingdom and Australia it was reported. Multiple case series and case reports are available in India where cucurbitacin toxicity were reported in the past. The diagnosis is very simple. If a patient is giving a history that he or she took something which was bitter from this family, and he or she came with upper gastroenteritis like features, diagnosis is very simple. But problem starts when the patient is not giving history or the patient came to the emergency department in a state where patient is in completely shock and altered sensorium. Then the problem starts. The prognosis is good if you give good resuscitation to these patients. The main issue is that you have to prevent this toxicity. Cucurbitacin toxicity is completely preventable. So how to prevent it? If your patient, if you are tasting vegetables or cucumber which is very bitter in taste, The simple option is just discard it, don't use it. And bitterness depends on the level of cucurbitacin. If it is more than 130 part per million, it will be bitter, and this will cause toxicity, and this will cause severe gastroenteritis like feature and shock. So it is very simple, but you have to be cautious when you are using these vegetables. So from next time, if you are using these Loki or juice or the cucumber juice, just taste it, slightly taste it, and if it is bitter, don't use it. It is dose dependent. Toxicity is completely dose dependent. If you have tasted very small amount, it will not cause any harm to you. And if you think that even if it is bitter, I will cook it at a higher temperature and the toxicity will go up, it's not the case. This cucurbitacin toxicity is thermostable. It is stable at a temperature of 600 to 700 degrees Celsius. So it will not help. So it is very simple. Just taste it, a small amount. If it is bitter, discard it. Thank you very much. Now the house is open for the questioning. If you have any doubts, please. Yes, sir.
For ages, we've been having Loki as sabzi. We cook it and have it. You don't even come to know because of the masalas or spices that they're bitter or not. Like you said that it is the toxin is stable even at 600 centigrade. It should be there in bitter bottle gourds also, which might be around. Why don't we have it once it is? I don't think Loki injection per se as a sabzi anybody would have toxicity of coconut. I was wondering, number one, that. Number two, you showed many researches. So, was there any attempt to scientifically describe that it was a cucurbitacin toxicity, or only that is it present in the blood, or it is just a local irritant to the mucosa? I mean, I didn't. Obviously, if it is local irritant, it'll fall into the cascade of gastroenteritis and vomiting and things like that. But is it sort of absorbed and you could actually measure it somewhere in the blood? Because all the evidences in all the cases are fully circumstantial, that somebody had a bitter drink and had this issue. Could be just irritant causing gastroenteritis. Then why do we call it cucurbitacin toxin? So just, I'm sure it might be a very lay question, but
So coming to your first question, sir, that if we are taking Loki Sabzi almost every week, so taste is taste the Loki first, just before making the vegetable. So, so the second part, that it is dose dependent, sir. If you are using Loki Sabzi, so it's it
in the blood.
yes, it is measurable, sir. But actually, you need a very equipped lab for that, and the methods by which you can actually measure it in either urine or blood, it is by high performance liquid thin layer chromatography. There are no other methods by which you can actually measure it, sir.
The test.
No, 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 not at all. So this patient came in shock with vomiting, multiple episodes of vomiting and loose stool. So it may be, and patient actually was in profound shock. So there are two problems here. First of all, cucurbitacin can have direct toxicity on the myocardium. Number one. So any patients, so inferior valve myocardial infarction sometimes can present with silent ischemia in profound shock with multiple episodes of vomiting.
Patient in
Diarrhea is
shock
very
and
rare.
vomiting.
Diarrhea is very rare.
But in this
Diarrhea is very, but we have to find out what is the reason for so profound shock, because patient was having non-recordable blood pressure.
Patient with shock and vomiting particularly will definitely get a tropidone, particularly patient with sinus tachycardia also. Regarding Dr. Amit Gupta's question, generally we take very less amount of sabji. To get 100 ml of juice from ghee, you require at least maybe 750 grams of ghee. If you don't take 750 grams of ghee sabji, it will take about 100 grams or 200 grams of sabji. Even if it is bitter, it is not going to produce symptoms.
So normally your toxicity dose is 100 to 300 milliliter of this syrup. It is in the whole. It is in the whole
Because most of the
bottle
time, yeah, yeah. So if you drink with the skin, probably you will feel it's bitter, probably. But
It is present in the whole
when it is made in a
fruit.
large scale, like in our mass, hostel mass, it's very difficult to taste everything.
So, coming to your question of myocardial infarction, why we suspected myocardial infarction, when you have shock, there are chances that this patient can develop prothrombotic states. So, pulmonary embolism and myocardial infarction should be ruled out, even despite giving fluids and patient's blood pressure is not picking. So, these things should be ruled out because these are completely treatable conditions.
Yeah, I wanted to, just say that the patient was in shock and there was history of vomiting. So in that situation, definitely, one should rule out a myocardial infarction
Yes, sir.
also. And the standard thing to do is ECG, and that should done within, the recommendations are there. It should done within 10 minutes. Apparently, what I was following, it seemed
Totally,
quite late.
totally agree, sir.
It was
Totally
quite late.
agree.
So that is one thing. Although the loose motions, that is generally not very common with MI.
It's not,
But
it's not
if
common.
the patient is coming like this, I mean, quick ECG immediately must be done. Troponin is normal, or depression only, not ST elevation. Suspicion is there of acute coronary syndrome, then troponin comes basically.
Definitely, sir. ACCHA says that from time of arrival to ECG, it should be less than 10 minutes. Thank you.
Thank you, Dr. Jamshed, for an interesting case. Moving on to the next case from the Division of Trauma Surgery and Critical Care, we bring in a very interesting case, and Dr. Pratyusha Priyadarshi will introduce her team for the presentation today.
Good afternoon, everyone. So, after this interesting case presentation by emergency medicine, we'll going to take you through an interesting case presentation. And Dr. Sahil, MCH resident from Division of Trauma Surgery, will present the case. And Dr. Preksha will discuss the case. And they will be helped by Dr. Piyush from Department of Radiology. Dr. Sahil.
Good afternoon, everyone. I'm presenting a case, a 21-year male who had an alleged history of road traffic injury, two-wheeler helmeted rider hit by a four-wheeler, brought by a bystander to our emergency department 1 hour post-injury. In our ED, we triage the patient based upon our set protocols. These are physiological parameters, injury identified, and mechanism of injury. So our patient was triage right. On arrival to the ED on primary survey, patient had a patent airway with cervical spine was stabilized with semi-rigid collar. Patient had a respiratory rate of 30 per minute and saturation of 96% on room air. With chest compression test was positive with decreased air entry on the left side. Patient had a laceration of 3 into 2 centimeter on the left infraclavicular location with EFAS positive in the left pleural space. So he was supplemented with oxygen and left ICD was inserted. Hemodynamically, he was tachycardic and hypotensive, for which 1 liter of pre-warmed crystalloid fluid was given, but his vital remains the same. His GCS was E4V5M6. On adjunct to the primary survey, he had a EFAS positive on the left pleural space, and after insertion of the left ICD, approximately 2.5 liters of fluid was drained, which was hemorrhagic, and his chest X-ray showed left hemothorax with ICD in situ with left clavicle fracture, and his ABG showed base deficit of -9.9 and lactate of 7.5. Based on his primary survey, the patient being EFAS positive with massive hemothorax and not improving vitals, he was declared as a non-responder. And it was continued along the line of damage control resuscitation, which is limited crystalloid fluid infusion, early activation of the massive hemorrhage protocol, tranexamic acid were given, and to control the early hemorrhage, patient was shifted to the operation theatre. On operation theatre, damage control thoracotomy through left anterolateral approach was done. Intraoperatively, there was 1 liter of blood in the left pleural cavity noted, and there was a small laceration in the apical lobe of left lung with no active air leak. And there was active bleeding from the left internal mammary artery, which was ligated. And hemostasis was secured. ICDs were placed, and patient was shifted to the ICU. On post-operative day 1, patient resuscitation was continued with thromboelastography-based blood products. Patient was afebrile, and his vitals were improving with adequate urine output, and his ABG also improved with base deficit of -2.9 and lactate of 1.5. Overall, all his parameters were improving, but the patient was remain hypotensive with bilateral upper limb mean arterial pressure of 52 millimeters of mercury. So we proceed with the detailed secondary survey as per our protocol. Bilateral upper limb noted to be warm with saturation of 100%. Brachial and the radial pulses were not palpable, and the mean arterial pressure of 52 millimeters of mercury were noted with there was no neurological deficit. In bilateral lower limb, it was warm with saturation of 100%. All the pulses were palpable with mean arterial pressure of 80, and there was no neurological deficit, and there was no significant ample history. So to summarize here, we had a young male who had a motor vehicle crash, underwent damage control surgery for the left massive hemothorax. He was in phase 2 of damage control resuscitation and improving with heart rate of 70 per minute, bilateral lower limb mean arterial pressure of 80, but he had a bilateral upper limb mean arterial pressure of 52 with absent pulses with no neurological deficit. So the possible causes for these anomalies are traumatic cause, as the patient had impacted on the left side with no feature suggested of right-sided trauma, even with the bilateral lower limb pulses present. We consider the other non-traumatic causes like bilateral thoracic outlet syndrome, medium and small size artery vasculitis, and bilateral subclavian artery stenosis. But in the history of trauma, until and unless proof otherwise, traumatic origin was considered. So we proceed with the adjuncts to the secondary survey. As the patient had a dangerous mechanism of injury and bilateral upper limb pulses were present, we proceed to go with NCCT head and C spine, CCT torso, and CT angiography of bilateral upper limb. I would like to call Dr. Piyush to explain us about the imaging.
Good afternoon, everyone. So we went ahead with the NCCT head and cervical spine for the patient, and there were no abnormality detected. Similarly, on the CCT torso images, we found out that there was a fracture of the manubrium sterni, left clavicle, left second and third rib, and there was a left-sided hemothorax with the ICD in situ, which was placed during the ED only. The bilateral angio was also done in view of the bilateral upper limb pulselessness, and we can see the coronal MIP images. And on these MIP images, we can see that there was presence of a long segment of non-opacification of the left subclavian artery, and between the second part of the left subclavian and the second part of the axillary artery. And in view of this, we raised the possibility of a thrombosis of this segment. Similarly, on the right side, there was a dissection flap, as we can see over here. We have pointed it out. This was the proximal segment, and this is the distal segment of the artery. And there was this dissection flap noted within it. And so we raised the possibility of a dissection flap with a short segment thrombosis in the proximal segment of the right subclavian artery. Handing it back to Dr. Sayal.
Thank you, Dr. Piyush. So our CCT had solved the mystery. Although it is rare and uncommon, but our patient had a bilateral subclavian artery injury. So the final diagnosis were the patient had a blood trauma chest, status post damage control thoracotomy with bilateral subclavian artery injury, right subclavian artery dissection with left subclavian artery thrombosis with no distal neurological deficit. So the major challenges this patient brought to us in this point were: patient was in hemorrhagic class 4 shock at presentation with ongoing resuscitation with massive blood transfusion, bilateral upper limb vascular injury, and there was a severe trauma as suggested by the injury severity score. And our major concern was risk of ischemia of bilateral upper limb. So the management point of view, our operative concerns were the patient was still recovering from the first surgery, so we were reluctant to do the other surgery, and the limbs were viable and functional even after more than 24 hours post injury. Bilateral subclavian artery open repair would have required extensive mediastinal dissection. So we discussed with our interventional radiology team, and a conclusion was made to go ahead with the intervention, that is on the left side, there was a thrombosis in the left subclavian artery with a good distal reformation. So we proceed with the non-operative management. And on the right side, there was a dissection with the intimal flap on the right subclavian artery. And there was a risk of progression and pseudoaneurysm formation. So we plan to go ahead with the intervention, that is endovascular stenting. I would like to call Dr. Piyush to explain us about the stenting.
So we decided to intervene on the right side, showing you a few spots from the DSA lab. This is the selective run which we took prior, like just the first run that we took, and we can see that the catheter in the selective right brachiocephalic, and we can see this is the common carotid, and this is the proximal segment of the right subclavian artery, the proximal segment, and there is non-opacification of the rest of the subclavian artery. We went ahead and we tried negotiating the guide wire, and luckily the guide wire passed into the distal segment. And moving on, and this we can see that we tried dilating the occluded segment, where we were able to pass the balloon into the occluded segment, and subsequently dilatation was attempted. And this we can see that this pain structure, this is the stent which was deployed, and this is the balloon dilatation which was subsequently performed to reopen the occluded segment. This is just to summarize the finding. This is the pre-stenting scan, and we can see that there was non-opacification of the subclavian artery, and only the proximal segment was opacifying. This is the post-stenting scan, where we can see complete opacification and of the right subclavian artery.
During the post-op course, ICDs were removed by post-operative day 6. And right upper limb pulses were palpable now, and the left upper limb pulses were not palpable, and bilateral upper limb noted to be warm with saturation of 100%, and there was no neurological deficit. And on imaging, there was a triphasic flow in the right upper limb arteries and a thrombus in the left subclavian artery with good biphasic flow in distal arteries. Patient was discharged on post-operative day 12 on antiplatelets. During follow-up at 1 month, on examination, there was no sign and symptoms of bilateral upper limb ischemia or neurological deficit. And imaging suggestive of left-sided thrombose segment with good distal reformation. But on the right side, there was an aneurysm at the site of the stent placement with a good distal flow. So we kept the patient under close observation. On further follow-up after 3 weeks, the size of the aneurysm was increased. So with the diagnosis of type 2 endoleak with sac expansion, and the neck of the sac was wide just near the origin of the right subclavian artery, we planned for a surgical intervention after discussing our CTVS team. With medial sternotomy approach intraoperatively by taking the proximal and distal control of the right subclavian artery, aneurysm resection with interposition, Dacron graft, end-to-side anastomosis was done. On post-op, right upper limb noted to be warm with saturation of 100%, brachial and radial pulses were palpable, and imaging suggestive of patent right subclavian artery. But on the left side, left subclavian artery had a thrombus with good axillary reformation. Patient was discharged on post-injury day 92 on antiplatelets and advised for regular follow-up. Patient, this is his last follow-up, which was done 4 days back. Patient is doing well. All his wounds were healed. There was no signs and symptoms of claudication or limb ischemia in bilateral upper limb. On examination, bilateral upper limb noted to be warm with no neurological deficit. Right upper limb, all pulses were palpable, and left upper limb pulses not palpable. On imaging, right subclavian artery showed patent decumbent graft with good flow. And on the left subclavian artery was not visualized, maybe because of thrombus, but had a distal monophasic high velocity flow. And patient was advised to continue on antiplatelets. I would like to call Dr. Preksha for the further discussion. Thank you.
Dr. Sahil. So here we've discussed a trauma case. What's trauma? Physical trauma, if I can say, is transfer of external kinetic energy to the body, leading to disintegration of structures and disfigurement of tissues. How we manage the case? It's along the ATLS principle. So in ED, we manage with the primary survey, where with the ABCDE approach, we address to the immediate life-threatening injuries. Once these are addressed and we ensure the patient is hemodynamically stable, we go ahead with the detailed secondary survey. Now the secondary survey involves a head-to-toe examination. This is with its adjuncts, we try to address to the potentially life-threatening injuries. And with that, we make a definite plan and for the patient. Now we have to understand the secondary survey is only imperative once the primary survey is done, patient is hemodynamically stable, and we're sure that the patient can move on to a further secondary survey. This need not be in ED. It's not essential that the secondary survey is to be done in ED itself. It's based on the patient's physiology. Now, as I said, according to the ATLS protocol, in the primary survey, we evaluated the physiology of the patient. We stabilized the patient. In the secondary survey, we evaluated the anatomy of the patient with the head-to-toe examination and its adjuncts. Now it's coming to the tertiary survey. This is done after the early resuscitative period, which is after 24 to 48 hours. Here, reassess the patient, repeat the primary survey and the secondary survey, look for any new injuries, reevaluate the patient, review all the investigations done, and advise any new investigations if required, and then readdress based on the findings. So it's reassess, reevaluate, readdress. There is a concept of quaternary survey where the institutes, where there's no facilities available, there's a transfer of the patient, which is to be an informed transport with all the details. What is the importance of all this? There's a potential of missing an injury, especially in an unresponsive or a critical patient, or maybe appreciating the significance of that injury for the patient's quality of life later on. Thus, the solution is the repeated assessments. Our protocol, we reiterate the findings again of the primary survey, the secondary survey, we reiterate again the biochemical and the radiological findings. Any new findings are noted, and then the plan is made again. So this is how we follow the protocol at our division. What's the importance? To look for the missed injuries. These are a trauma surgeon's nemesis. There's no consensus on definition. Broadly, these are the injuries which are appreciated after 24 to 48 hours, or maybe after initial workup is completed and the diagnosis at admission is determined. Missed injuries are now considered a common indicator for trauma care quality improvement. They are present about 1.3 to 39% of rate as per different literatures, with the clinical significant ones being about 0.2 to 8.7%. Repeated surveys have shown to be significantly decreased this rate of missed injuries. Presence of life-threatening injuries or a decreased conscious, low GCS, high severe injury severity scores suggestive of severe trauma, or even a distracting injury are most likely associated to be with an increased rate of missed injuries. There's the different literature showing the rates of the different injuries. All of them mainly are found to be musculoskeletal. Even in a review of our literature, our department, we've seen over the last 5 years, the trend, it's about less than 1% of missed injuries, with the 12% of those being clinically significant. These are mainly musculoskeletal and spine. These are the various evidence showing the importance of tertiary, the repeated assessments to find out any missed injuries, so that there is even this systemic review or the meta-analysis from well-established journals have shown that there is an importance of these repeated assessments. The lessons learned for us in this case. This was the only reported case of bilateral subclavian artery injury in English literature as per our knowledge. We managed them according to the lines of unilateral subclavian injury individually. Here, by utilizing the multidisciplinary approach from the our ED colleagues, emergency medicine colleagues, to us trauma surgeons, anesthetists and critical care intensivists, radiologists, even the CTVS team, by a multidisciplinary approach, we could optimize the care, minimize the morbidity of the patient. This subclavian artery injury had a high potential of being a missed injury, especially the one which was on the right side. Why? The patient in the ED was a non-responder. We could not do any detailed investigation then. Even in the OR, the massive hemothorax was due to this other vascular trauma, which is the left internal mammary artery, not the subclavian artery. Even in the ICU ward, patient never complained of any pain or any ischemic symptoms or neurological deficits in either of the limbs, the right side specifically. Only being vigilant and following the protocol of repeated surveys could we avoid any delayed complication. The take home message I could say, this case definitely reinforces the definition of trauma, where there's a transfer of energy. And this does not follow anatomical boundaries, which is very well reinforced again here. Dynamic status of the patients in trauma involves dynamic decisions, and only by being following protocols, by following the mantra of RRR, re-examine, re-evaluate, and readdress, could lead to an improved and successful outcome. Thank you.
Very good evening, House, and thank you very much, Dr. Peksha, Dr. Piyush, and Dr. Sail for such your elaborative presentation. And with this presentation, you justified the legendary title RRR as well as reinforced the importance of developing and following the protocols. So, in few patients, there may be over treatment, but it is the protocol only which save us from the rare missed injuries, as we have learned from the air traffic industry. And with this comment, I please, sir. Sir, uh, probably, sir, more than 24 hours, 24 hours, 24 to 30 hours.
So how do you explain the collaterals on the left side? Because in acute vascular injury, the collaterals should not be there.
So it is not, sir, collateral. It is basically the circulation, distal circulation, which is being taken up by the other branches of the distal part of the subclavian vessel, you can say, not the collateral per se.
No, that's all right, because in your presentation it was mentioned that there was good collateral flow.
So collateral, basically it is the reverse filling of the artery.
Actually, rather than a collateral, it is the re perfusion from the
retrograde perfusion. Retrograde perfusion. Yes. So there are arcade around the blocked part, and then the distal part will be perfused by the some other branch of the subclavian artery. Yes, sir. There should not be. Totally agree, sir. Acute presentation. No, sir. The thrombosis was on the left side, and the dissection flap was on the right side.
Okay.
So, in the view of trauma and with the other finding of rib fractures, it is very, very unlikely that it is just a,
Even you have placed the endovascular stent there. Why patient was not given any anticoagulant?
Sorry, patient was on antiplatelet, and patient is still on
antiplatelet is for basically when there is already a formed thrombus, the treatment of choice is anticoagulant, or you have to give some thrombolytic therapy.
So, as far as
is there any was there any contraindication for giving anticoagulant in these patients?
Yes. So
dissection is one.
So patient was having two problems. One is on the left side there was thrombus. On the right side there was dissection flap. For left side we planned to patient manage non-operatively, and on the right side the stent was deployed. Now, as you rightly said, for the thrombus, anticoagulant should be given. But you consider the patient who is post 24 hour, he has undergone a major surgery. He is still receiving, major blood transfusion, and we don't know the very exact status of the hemodynamics, how he will behave further. So, in these cases who are supposedly non-clinical, I would say subclinical coagulopathy already persisting, we generally don't give the antithrombotic agents. As far as the antiplatelet agents, it is our routine practice to give patient on antiplatelet after any foreign body deployment, like the stent, which is done in this patient in the proximal vessels. We don't do that so in every vessels also.
Aorta and the major arteries, we do not give regular anticoagulation. This patient, in addition, had massive hemothorax. Already thoracotomy was done. So immediate installation of or starting of any coagulation did not do that. But yes, because a stent was placed on the right side, there is a routine that we would give antiplatelets in the patients in which we either do a prosthetic graft for arterial sort of replacement of the anatomy, or do a stent. I think antiplatelet is sufficient.
Okay, sir.
In high flow systems, only antiplatelets. Oh, yes, we have given in many patients intra-arterial thrombotic.
So for that, sir, we have to be very sure that there is no other source of bleed. We have to exclude that. So in this case, he had pneumothorax. We tried that. Earlier, isolated cases of they have done, but majority of them they undergo surgical.
So at times the landing zone is not complete, or at times what happens is that the defect is bigger than the not
Actual diameter
completed
of
within
the
the
stent.
landing zone, and therefore you might have certain leaks, and they are known. I
In
mean,
this
with
case, went across the vertebral artery. So although we have done pretty good number of subclavian stenting, but we never blocked the vertebra as a prophylactically. Retrogradely filling from the vertebral artery.
And there's some ischemia also. Aneurysm develops. After
No,
putting
no,
this
he, he never had any ischemia.
It was an endoleak kind of a thing. It was not a true aneurysm. It was
it is true aneurysm.
yeah.
So basically, we wanted to highlight not only the rarity. Obviously, this case was rare. It was also rare because there was no direct impact to the right side, and still we had a major high flow vascular injury on the right side. But at the same time, we wanted to highlight that these are the cases which would be generally missed. You know, especially in a very sick patient who is undergoing resuscitation, emergency thoracotomy, taken to the ICU after thoracotomy, and then getting resuscitated. So, and especially intubated patient, he would not complain of anything. So you have to be vigilant in each and every case, especially these high velocity motor vehicle crashes, which can cause systemic injuries rather than localized injuries. Any other comment or
other query from the house? Thank you, sir. Thank you very much to all of you for sparing your prestigious time. Thank you.